Medications for opioid use disorders in correctional settings. Shifting the paradigm, creating a balanced correctional and rehabilitative approach. The Opioid Response Network is funded by SAMHSA to provide resources and technical assistance needed locally to address the opioid crisis. This video is part of a series to provide guidance on the implementation of medications for opioid use disorder in correctional facilities. Leading corrections and behavioral health experts present information on topics such as the use of medication, models of delivery, diversion, and linkages to care and community support. An interview with Barry Weiner, Rhode Island Department of Corrections.
My name is Barry Weiner, and I'm the Assistant Director at the Rhode Island Department of Corrections. I oversee all of rehabilitative services, and I've been in the position for about 5.5 years.
What challenges might arise when a correctional facility is implementing an MOUD program?
I've been working with the justice-involved population for about 40 years now, so it's been a long time. And I've watched people with substance abuse disorder just struggle horribly. I mean, addiction is an awful disease. It ruins lives, and it's very, very treacherous. And historically, people would come into the criminal justice system. If they were abusing, we would wean them off of the drug and watch people get drug sick, which is something that's really awful for folks that never saw that. Imagine the worst flu you've ever had and the worst food poisoning you've ever had, and put those both together and increase it by 10. That's what it feels like to be dope sick. And that was happening in prisons. And then many folks that come into our system get out very shortly thereafter. And then what happens? Inevitably, they would return to addiction. So MAT is really the gold standard for opioid use disorder. And it works and it saves lives. In Rhode Island, we reduced the deaths of overdoses by 60% since instituting the program. So those are just miraculous results. So how do you go in a prison environment where this is so counterintuitive to everything we've always done? Our security staff has trained for decades. How do we keep drugs out of the facility? And now we're telling staff, we're going to bring drugs into the facility, and it's a good thing. So as you might imagine, that doesn't go over very well, and there's a lot of resistance. So I think the most important thing about having a successful program is to deal with buy-in, and it has to be dealt with early, or the program is not going to be successful. The first part of buy-in is really education to break down some of the myths around substance abuse and about addiction. People need to understand that it's a brain disorder. It's not a matter of willpower, like, oh, if they only wanted not to use, they can. It's like many other diseases that we deal with. And it's a horrible disease. It's ruined lives. We've seen people come into our system and that use drugs. They don't want to be addicted. They don't want to be in this position. Broken families, lost jobs, financial things. Their life is just in ruins. And we now have a key where they can turn that life around. They can get sober. They could once again reunite and build family relationships. They could get jobs. They could start paying taxes for the first time, maybe. Get a legal driver's license. Not have to look behind their back, worried about being arrested all the time. And certainly over the years since MAT has come around, I've seen so many changed lives. Many individuals who have been released from our system successfully on the program, they remain successful in the community, and they come back and just talk about how their life is just so different and so amazing, something they never thought would happen. So we had to do a lot of education with staff, because if you want a culture to change, people have to understand why. Why are we doing this? So explaining to folks why we're doing this had a big impact so they could understand it. It takes a lot of teamwork. You need a combination of high-level buy-in And we had that from the governor of our state in Rhode Island. So we were very, very fortunate. To community members, the Department of Health, agencies like Kodak and others that provide services in the community. You need a wonderful director who's going to support you, and we have that in Director Trish Coyne-Faig. Medical director who has buy-in, and all the way down to all staff, including the newest correctional officer recruits. So you have to include everybody in the training and the education. We found it very helpful to get people at the outset. We do a new employee orientation whenever new folks come on, and we're sure to have a segment on MAT in that program. Also, once the program gets started in the facilities, there's inevitably going to be communication issues where security is not going to understand why medical is doing what they're doing, and medical is not going to understand why security is doing. Because let's face it, we come from two different worlds in our training, and we see the world through two different lenses. And both lenses are crucial and important, but they're different. So regular meetings between the different entities to share issues that are going on, concerns, problems. If there's diversion, why is the diversion happening? Is it happening? How is it happening? How do we prevent it? There's a real need to unite and work together to solve some of those things.
Was buy-in the biggest challenge in developing a successful program?
It was certainly one of the biggest obstacles because we have 6 different facilities. I know many states, some have more. We have wardens in each facility that run the building, and every building just runs differently. And things could happen. If folks don't understand, they're not going to support the program. Let's face it, security runs on a schedule. It's very organized. When you put a program in that changes that schedule, it can be very, very difficult for security. And some of the adaptations that need to be made can be complicated. So it did take a lot of work, a lot of discussion, a lot of trust building, and a lot of seeing the evidence that this program really does work. Now, we got a lot of buy-in from security when they started seeing the results. People weren't getting dope sick anymore. Cells didn't have to be cleaned. It didn't smell. Fewer hospital trips were being made. Less fights in the facility, less argumentation, less folks had to be disciplined. So actually with this program, we saw a much smoother running facility, and the shift went a lot easier. And that was a benefit for everybody.
Was it a surprise to see the facility operate more smoothly after the implementation of the program?
No, we did anticipate it, and it's something we knew would happen. So, of course, the impetus in the program is to treat people for their medical ailment. But we knew a collateral consequence would be, if we were successful, and fortunately we were, a smoother running facility with less problems, less expense. It's very expensive when we send somebody out to the hospital. Medical care is very expensive. So having things run smoothly, getting people into treatment and programs was very, very beneficial.
What percentage of the population do you estimate has an opioid use disorder when they enter the facility?
Well, probably substance abuse disorder, people would probably runs at about 85% or so. The OUD number is significantly lower than that, but it is significant. We start with an initial screening by just asking somebody, have you used illicit opiates? And if the answer is yes, they then get referred for a more comprehensive assessment. And people use at different levels for different lengths of time, for different purposes. You know, some people start with a legitimate medical ailment, maybe a broken bone or being in an accident, and they're prescribed medications for that disorder. And ultimately, when that prescription term ends, because the effect was so wonderful and affected some brains in a way that they just don't want to discontinue, they continue with illicit drugs. I spoke to a physician friend who was in a skiing accident and broke his leg and had never used opioids before. But when he went to the hospital and had to get treated for his leg with some surgery, he was given opiates. And he said to me, Barry, I never had such a euphoric feeling in my life. It was amazing. And I knew that if I stayed on this medication, I was going to have a problem and I wasn't going to be able to stop. And he never knew that about himself before. And he talked to a friend who had a similar surgery to him some time ago, and she took the same medication, and she said, it had no effect. I don't know what you're talking about. So, so we're all different, and every case is different, and the need for treatment varies.
Over the course of your career, what changes have you seen in the treatment of opioid use disorders in correction facilities?
It's just a world of difference with the program. The system always felt before, if somebody was an opiate user, our goal was to wean them off of the drug. And once we did that, we cured them, right? They're not using drugs anymore. And we thought we did a good job, and we were proud of what we did. But ultimately, there was a lot of smuggling into the facility of drugs. People were trying to get out the drugs, and those that couldn't get the drugs, inevitably, for the vast majority, when they got out, they began using again. And we saw the cycle. So after a while, you start thinking, is this really the right way? And then through the MAT program, when we got people on the medication they needed, we found they were stabilized inside. We provided education, and we provided psychosocial counseling. The thing I think everybody has to remember about MAT, and the thing we forget sometimes, is medication-assisted treatment. It's not medication alone. In fact, the evidence says, and the science says, that medication alone is not going to solve the problem. It's the combination of the medication and the services. So once somebody is stabilized on medication in the prison, they're then able to receive and participate in those other services. And most important for the program is to be sure there's a connection to a provider in the community when they get out. We're very fortunate in Rhode Island because we have a provider like Kodak, and they actually provide services inside the prison. So the day somebody is released on the program, they know where the program is, they know who their counselor is going to be, they know how to get there. We make sure they have bus fare to get there. So it makes for a very, very smooth transition, although I know that can't happen in every state in the country for lots of reasons. So with that, again, folks are staying out longer, folks are doing well, folks are living productive lives. We hear from families, we hear from mothers, we hear from sisters, we hear from spouses, thank you, I thought I lost him, or I thought I lost her. I thought life would never be the same again, but it is. And that's really very rewarding.
Technical assistance is available to support the evidence-based prevention, treatment, and recovery of opioid use disorder. To request technical assistance, visit opioidresponsenetwork.org.